Welcome to the EMT Pro podcast, where we deliver relevant EMS content from the field and the classroom each week. Each episode of this podcast can get you 1 full hour of CE through our partner, emt-ce.com. So head over there for more information. I'm your host, Steve Williams, and with me today, faithful co-host Dan and Holly. Holly's back in the studio, Daniel.
Oh, thank goodness.
Good to have everybody back.
So good to see her.
And in true trio fashion, we're talking about a triad of sorts today.
Oh,
You like that segue? Not just any triad, the trauma-death triad.
Yes.
But in Holly's notes here, she goes, okay, fine, call it a trauma diamond.
Yes.
Yes.
Can't forget calcium.
Yeah.
The new
So
one.
we're going to get into all this. It's going to be fun.
So
Define what it is.
the trauma triad. Hypothermia.
'Kay.
Acidosis.
'Kay.
And coagulopathy.
And then
which
we
we'll
throw
deep
in
dive
a fourth
into.
one in there,
Calcium.
calcium. Hypothermia, acidosis, coagulopathy.
But trauma death triad sounds so much better than trauma
It's going to
death
grab
diamond.
more. Yeah.
Yeah.
It's going to grab more people than
Yeah.
what else would you call it? A trauma square?
hmm But don't worry, we'll talk about calcium.
A death
Everyone
square?
says. Okay, so pop quiz.
'Kay.
What is the leading cause of death in 50% of trauma patients within 48 hours of arriving to the hospital?
I know because I have the slide in front of me. But Daniel, do you want to guess?
Jeez, no. That's not fair.
Uncontrolled hemorrhage.
Oh, well, you said within 48 hours. It's really within 48 hours?
Yeah.
It's uncontrolled hemorrhage?
Yeah. Crazy.
Of
huh?
arriving to the hospital. Not in the field, the hospital.
Wow, I did not know that.
Yeah. 50% of trauma patients that die within 48 hours,
Jeez.
uncontrolled hemorrhage, which we can do stuff about, right?
Yeah.
So trauma statistics in 2022, there were 222,698 preventable deaths,
Jeez.
which included about $1.2 billion in costs for trauma. So that's why this is important. So we talked about what the death triad is, or the lethal triad, or the lethal diamond.
Mm-hmm.
But we'll talk about that a little bit later. Where should we start? Should we start with hypothermia? It's the
I
easiest
think
one.
we need to start by just giving our listeners a very brief
Mhm.
life update on you.
Oh,
Because not only is Miss Holly a fun RN, as you like to call yourself, she is working on her doctorate.
Yes.
Yes. So we are the benefits of her amazing education and continued education.
oh,
So
excellent.
thank you for your
Thank you.
expertise, Holly.
You're welcome.
Hey, I'm a high
Um,
school graduate. Class of 83.
Hey, her accomplishments don't need to come at your expense of, us acknowledging how great you are.
Okay. Thank you. Thank you. Are we ready?
Yeah.
Okay.
Hypothermia.
Hypothermia. Does anybody know what hypothermia is?
Very cold.
Core body temp.
I'm that
Being
right
cold.
Yeah.
I would like to take a poll of all the EMS folks out there who's actually used the thermometer in the rig. I don't know if I ever used it.
I've used a couple of them. I don't feel like, because they're stored in that cold
now.
box of the ambulance, it never felt like it was very
It's
accurate.
not accurate at all.
Yeah.
Same. So when you talk about normal body temperature being 97.5 to 99.5, I mean, does that really matter to us? We're not going to be taking people's temperatures.
Mhm.
But if you want to get scientific about it, hypothermia is defined as a core body temp of less than 95 degrees Fahrenheit. I don't know if anybody, I'm a nurse, so I work in Celsius, but
Right.
we can talk about Fahrenheit.
Probably need to do both.
Yeah, so 35 degrees Celsius, 95 degree Fahrenheit. Anything less than that is hypothermia. Or did they feel cold?
Right.
Mhm.
Or do they is it cold outside? Or are they a trauma patient?
Right.
If they are hypothermic.
Yeah. You just assume they're cold,
Just assume that.
regardless of what season it is.
And some of the statistics show that, this is from ATLS, 10% of all injured patients are hypothermic. And approximately 1/3 of severely injured patients are hypothermic. So just always remember, and we've heard this 1,000 times, if you're not sweating, your patient's too cold.
Mm-hmm.
It doesn't matter if it's 90 degrees outside. If you have a trauma patient, they're probably hypothermic. So just always consider that. And I don't like to be uncomfortable. I
No.
hate it when I'm like sweating in my
your
gloves. It's
gloves,
like
right,
dripping down
yeah.
your arms.
Right.
But that means you're probably doing it right if that's the case. If you go into any trauma center, when you walk into the trauma bay, it's hot. Like they have the panels on the ceiling. When I did my EMT certification, you have like the skills sheets, and then they have the critical fail section. And one of the critical fails is you didn't keep your patient warm. Literally thought that was just so sweet of us. Like, oh, we're just keeping people warm, and
we don't want them to be chilly.
No, I had really no idea that it really decreases the mortality of trauma patients just by keeping them warm. So this is probably the easiest intervention we can do as providers. So because trauma patients are so fragile in their ecosystem, hypothermia is classified differently in trauma than in regular patients. So if you have mild hypothermia in a regular patient, that would be 95 degrees to 89.6. That's mild hypothermia. But in a trauma patient, 96.8 is considered mild hypothermia. So if you want to talk about Celsius, 36 degrees Celsius in a trauma patient is mild hypothermia. So just think about if a normal patient is cold, just know that the threshold for hypothermia in a trauma patient is way less.
Okay.
So what kind of things contribute to hypothermia?
Like if they're laying on a cold pavement?
Exactly.
Yeah,
Environment.
Hydration level?
Yep. Alcohol
Yeah, I
intoxication.
was going to say like underlying health of the patient in
Yep.
general, medications potentially.
Traumatic brain injury.
Yeah.
Hemorrhagic
Blood loss.
shock.
Yeah, because we just
Part
said
of our
that.
triad, right?
Yeah.
Did you guys ever see the Mythbusters where they were going to prove that drinking alcohol makes you warmer? Like
No.
drinking whiskey
No.
makes you warmer. So they sat in a freezer all night and drank whiskey. And it turns out it doesn't keep you warm. It actually makes you colder, but you just don't care. So, yeah. And then the biggest question I have for you is, what about cold IV fluids? Do you have a fluid warmer in your
We
ambulance?
do have one.
Yep.
That is just amazing.
Yeah.
Lots of places don't.
Yeah.
They're expensive. They break. I used to work with a guy who put zippers on his shirt, and he would just unzip his shirt and stick the fluids in his shirt and zip it back up when we went on a trauma call. But that's not warm enough. Or throw them on the heater on the way to the call.
Yep.
So cold IV fluids, we're contributing to their hypothermia with cold IV fluids. And IV fluids are actually problematic when it comes to coagulation, hypothermia, and hemorrhagic shock. So we'll talk about those later. So how do we keep people warm? We talked about the contributing factors. So if you have massive blood loss, that's contributing to their hypothermia. What are we doing for that? Tourniquets.
Tourniquets, stopping the bleed.
Stop the bleed. Pelvic binders.
Mm-hmm.
I was just recently at a conference in Middle America, and a lot of people there don't really use pelvic binders. In fact, they're kind of still thinking that if you put a pelvic binder on someone that doesn't need it, that it's detrimental. And that's not true. So put a pelvic binder on everybody. You're not hurting anything.
Yeah.
Or we'll just use a blanket. Have you ever tried to bind a pelvis with a sheet?
A cravat. Yeah, it's like, shut up, dude.
It's
that
very
doesn't
difficult,
work. And it's not, it's us MacGyvering our way out of a situation that we don't have to.
Yeah.
We ended up implementing the SAM splints version, and now everybody's like on board and loves them because they relieve some pain for people that have low back pelvic fractures, and man,
and they're so easy to put on.
and they're easy to put on.
Yeah.
And they also prevent you from bleeding out, which is
Right.
win-win.
I've been tricked personally a few times in my career where it's like, oh, remember when we used to be like, the pelvis is stable.
Yeah.
Or we don't rock the pelvis anymore because that's bad. How do you know the pelvis is stable? Is there a mechanism of injury for a pelvic fracture? I remember taking an elderly person into the ER when I flew with Life Flight. And so I was like, oh yeah, pelvis is stable. Couldn't figure out where she's bleeding out from, and took her to CT, and it was shattered.
Wow.
And I was like, I should know better at this point in my career that obviously her pelvis is shattered. She's elderly. She was on autoped. why didn't we put a pelvic binder on her?
Right.
Like, I'll never forget that. Because
You
it
put a
was,
C-collar on her, right?
Sure,
Yeah,
absolutely.
we do that all the time.
Right.
But we don't put the pelvic binder on.
Yeah, it was just like, okay, I'll never do that again. And then, but at that time, the pelvic binder wasn't accessible. It was like in the
Yeah.
aft compartment.
Yeah.
So we moved it up to the jump kit so people would start using it more. And I think that's part of it too, is if it's easy to grab, you're going to use it. So people listening, put your pelvic binder somewhere where it's easy to grab. Just make it part of your flow. Okay, so we're talking about how, as EMS providers, are we going to prevent or at least mitigate hypothermia? So heaters, blankets, right? Warm IV fluids if you have them. Another thing to remember is balanced resuscitation, which we'll talk about during hemorrhage and coagulopathies. But balanced resuscitation also helps with hypothermia, because if you think blood loss is heat loss, we want to make sure that we're keeping that warm blood flowing and not replacing it with cold IV fluids. And again, if you aren't sweating, your patient's too cold. So we want to do that. That's probably like the easiest part of the triad, but that's something that we can definitely help. I know that we've seen lots of fire departments in different ways to keep people warm on scene, like those big blowers that you guys have.
Yep.
Or even they have those big blankets where you open them and it's like the hand warmers. Where
the ready heats.
Yeah, the ready heats. Those are amazing.
Yeah.
And they last for like 8 hours. So if you have a long extrication or something that you're that they're going to be exposed to the elements for a long time, think about keeping them warm, not just the blanket you put over them to keep them from getting glass all over themselves. But that probably helps a little bit. So, anything else about hypothermia to think about?
I mean, I'm curious to see where this goes in terms of learning about hypothermia in trauma being different than how we discuss hypothermia in other areas. Because I remember learning it in stages like 1 through 5.
Yeah.
And this is mild, moderate, severe, which I like simpler.
Yeah.
Much
It's a little
easier.
simpler, yeah.
Yeah.
And it makes sense because when you think about hypothermia in a cardiac arrest, for instance, you don't want to give epi. Why? Because your blood's not flowing. And if your body isn't within a normal pH or a normal temperature, the medications are not going to work appropriately. In any chronic illness or acute illness or severe illness, if you're hypothermic, it's going to shift your pH. It's going to make your blood not clot and all the bad things. So, okay. And every one of these things feeds into the other. Hypothermia makes coagulopathy worse. It makes acidosis worse. Acidosis makes hypothermia worse, and it makes
Keeps
so
going.
it just is a vicious cycle. So at every point with a trauma patient, we should be trying to intervene to slow down the process, if not prevent it or stop it. All right, should we talk about acidosis?
Yeah.
This one's kind of hard to talk about without a visual because it's pretty complicated, but we'll try to make it easy. So acidosis is a pH of anything less than 7.35. So the body likes to be between 7.35 and 7.45. That's a pretty small margin,
Little
right?
window. Yep.
Pretty small window. And we're not checking people's pH out in the field. We're not going to, whip out the I-stat and do a blood gas or anything like that. So what we just need to think about is all of the things that we're doing that could contribute to acidosis and try to mitigate those things.
I mean, with blood gas imbalances, you want to recognize it quickly, but you don't want to rapidly try to whip it back into something normal.
The only thing you want to fix
Right.
is respiratory acidosis.
Yeah.
Or alkalosis. You don't want to fix metabolic processes quickly.
Yeah.
So if you can figure out what the underlying problem is, if you have a trauma patient with, a CO2 of 20, that's probably respiratory acidosis, or it could be metabolic. But if it's a trauma patient, you can kind of figure out what the underlying problem is. Same with this acidosis. Like we have, what we're going to be talking about anyway, we have in the setting of trauma, there's some acute thing that just happened. We're not in the ICU taking care of people 3 days later, which gets a little bit, different focus. This is immediately. And some people have hours-long transports. Even if you have a 30-minute extrication and a 30-minute transport, that out of hospital time makes a big difference if you don't think about this. So our bodies are really good at keeping our pH normal. We have the kidneys are really good at it. Our respiratory system's really good at it. If we start retaining CO2, we're going to try to breathe that off, faster. But one of the main contributors to acidosis is poor tissue perfusion. So we're going to go way back into high school biology here in a minute and talk about that. But if you think about poor tissue perfusion, what are some of the things that contribute to that?
Hypotension.
Yeah, absolutely. Hypoperfusion, shock. So that could be hemorrhage.
And then it's
blood
all
loss.
the underlying things they may have had prior to.
Hypoxia. So we'll talk about some of those in detail. But if you just think of some of the things our trauma patients are experiencing, they're cold, maybe they're not breathing well, maybe they've got a traumatic brain injury, maybe they're bleeding, maybe they're diabetic. That is a whole nother issue.
Whole other thing, right?
Yep. So yeah, there's lots of things that can contribute to acidosis. Even if we don't know if they're in acidosis, think about all the things that could be going in that direction. And remember, if they're bleeding, that's going to contribute to acidosis. If they're cold, that's going to contribute to acidosis. So something we should be thinking about. So back to high school biology, and we can put this slides in the show notes.
Sure.
But just remembering back to the old Krebs cycle.
Oof.
I know it's a tough one,
Yes.
but we'll just
Make an ATP.
We'll just make it easy. Aerobic versus anaerobic. So aerobic metabolism is with oxygen. So you're going to create lots of ATP and lots of energy. Anaerobic, remember, is without oxygen. And interestingly, the aerobic metabolism takes place in the mitochondria. If you learned anything from high school biology, it's the mitochondria is the powerhouse of the cell. Everybody remembers that part. But anaerobic metabolism takes place outside of the mitochondria in the cytoplasm, so it's not very efficient. And if you don't have oxygen to make energy, your body's going to break down fat and things into lactic acid, right? So you're not perfusing well, you're not getting oxygen to your tissues maybe because you don't have enough blood. Maybe you're not getting oxygen to your tissues because you're not breathing well enough or there's some kind of obstruction. And your body's going to create energy any way it can. And in this case, if you are in anaerobic metabolism, you're going to start creating a lot of lactic acid. So that's going to contribute to your acidosis too. So let's talk about hypoperfusion and shock and how that contributes to your acidosis, because that's a lot of our patients are in shock, right? And remember, hypoperfusion isn't necessarily low blood pressure. It just means you're not getting enough blood to your tissues, blood and oxygen to your tissues, okay, for lots of reasons. So lactic acidosis, we just talked about it. And fun fact, we'll talk about lactated ringers later, but that is the one thing that buffers out the lactic acidosis. So that's a good thing to give to trauma patients. Inadequate oxygen delivery for whatever reason. Vasoconstriction, maybe you're cold, you're vasoconstricting, maybe you don't have enough blood, you're reducing any oxygen supply to the tissues. And then impaired clearance of lactic acid. If you have any kind of kidney injury, what's the first thing to go in trauma? Anytime your body is insulted, your kidneys go first, right? So maybe they're not performing as well, and they're not able to buffer out that acid.
So, Daniel.
Yeah.
There's a lot here.
Yeah.
There's a lot here.
I'm thinking we are talking about contributing factors for acidosis.
Mm-hmm.
And this chunk of information is specific to hypoperfusion and shock.
Mm-hmm.
And my brain goes to, okay, we have all this great knowledge. And how much in the face of trauma when you're in the field are you considering these things as you're treating a patient? Or do you know what I'm saying?
Mm-hmm.
Well, if you bring it up a little bit, it's we make sure they're oxygenated.
Yep.
Mm-hmm.
We make sure they're warm.
Yeah.
Mm-hmm.
We make sure that they're
Not bleeding out.
not bleeding out.
Yep.
Right.
Replacing fluids is needed.
Right.
Mm-hmm.
Trying to keep their blood pressure at
Right.
a low but healthy level.
Right.
Yeah. Balanced resuscitation,
Yeah.
because your crystalloids can cause acidosis if you give them too much. Hyperchloremic acidosis is something that does happen with normal saline. So thinking about that balanced resuscitation is really important during this one.
100%. And it seems to me like when we're on a call and we've got 50 things we've got to get done, we get into task saturated mode, right? And we're just boom, 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 knocking things off our list because we know that they need these things. And then if you can get to the point where, or if you have enough people on scene where you can have someone who's thinking, 100-foot level versus 1-foot level,
Right.
and considering all these aspects of it, it can be that much more of a well-rounded care for that patient.
It's kind of like when you know what you have in your toolbox
Yeah.
and you know how every single thing works. Then when you have the big problem, you can just reach for the one tool that you know is going to work. Or same thing with medications. You have a blood pressure problem, you know which medications to grab because you know how they work. That's kind of how this is. If you understand like the underlying factors on a deeper level, during that moment, you can just be like, oh, we got to keep them warm, balanced resuscitation. We got to stop the bleed,
Totally.
It just kind of makes you work a little bit more efficiently and remember the easy stuff to forget, like keeping them warm. I don't know how many. I remember when we were flying, we used to do customer surveys, and the biggest complaint we got was that people were cold.
Really?
Yeah.
Okay.
Like we know better.
Right.
And that's what you're going to complain about.
Yeah.
But that's really important to us because we were not keeping people warm that could talk and remember it. What about all the trauma patients we had?
Yeah.
So let's do a quick recap of acidosis contributing factors, and that way we'll know how we can stop contributing to those or how we can mitigate it. Or if we can't mitigate it, we at least know I'm doing this to keep the patient alive. It's probably going to make them more acidotic, which is going to make them bleed more. Let's keep them warm. Like there are certain things you can't fix or really change, but you can maybe change another part of the triad to mitigate the bad outcome. So we have hypoperfusion and shock, blood loss and resuscitation efforts, which is that balanced resuscitation. Hypoxia, remember, increase in CO2.
Yep.
Can lead to respiratory acidosis. Cellular and metabolic dysfunction. The only reason I bring this one up is because think about crush injuries and rhabdomyolysis.
Yep.
Again, you've got tissues that are being crushed, so you're not getting a lot of blood flow to them, which means you're probably creating a lot of lactic acid, and that's going to contribute to their acidosis too. So not much we can do about that, except are people still giving bicarb in the field for crush injuries?
Yes.
So that is one way to mitigate that. But just remember, all of these little things are contributing to their acidosis. So let's talk about crystalloids really quick. So we do normally have LR and normal saline on the rigs for lots of reasons. LR would be the preferred resuscitation tool. Unless you're giving blood, you can't give blood with LR. It has to be normal saline. But if we're not carrying blood and we have someone bleeding out and we stop the bleed like we're supposed to, unless it's a belly, what if the belly's bleeding? There's nothing you can do about that.
Right.
We're going to give them fluids because that's all we have. So you have to give them fluids. We're talking about balanced resuscitation where you want to keep their MAP above 65, but at the same time, do you want to just keep giving them liters and liters of fluid to do that? So we're always stuck in between a rock and a hard place. But just thinking about the crystalloids you carry, normal saline's pH is 5.5. Remember, our pH 7.35 to 7.45. So we're giving them a solution that is an acidotic solution. And truly, it can cause metabolic acidosis because you can get into a hyperchloremic state with too many crystalloids in the form of normal saline. It can also increase tissue inflammation, which leads to a coagulopathy. So you're giving all of this normal saline. Just remember a systolic blood pressure of 80 is probably good enough. A MAP of 65 is probably good enough. If it's a TBI, maybe MAP of 70 would be better.
Yeah.
but you're doing what you can to balance it with what tools you have. Lactated ringers, on the other hand, the pH is 6.5, so it's a little bit closer, and it contains calcium and is incompatible with blood products. So you have to remember, if you're giving blood, you have to do it with normal saline. I remember...
Can you just run it a different line?
Totally. And like tape your blood tubing to a bag of normal saline or something like that so you don't accidentally grab LR. But LR is better also because it can also buffer out the lactic acid. But you think lactated ringers, why would I give that if we have too much lactic acid?
Because it's less acidotic than saline.
Yeah.
Yeah.
Yep.
See me, I put that one together, Daniel.
Jeez. Thank you.
And also, the lactate in LR is buffered out by the kidneys and creates bicarbonate. So that's another buffer that can be used in the system to buffer out the lactic acid. So,
Sweet.
yeah, the liver's pretty cool. So, if you wanted to look at the show notes, there's a slide about all the different components of LR versus NS and why one is better than the other. So, I used to work with a trauma surgeon that would be like, normal saline kills people. Stop giving normal saline.
Was he being dramatic? Or
no, he was being real. I mean, this was like 15 years ago too, but he was a trauma doc and worked in, overseas and in a military setting and did a lot of studies on this. And it's true. Yeah, you can really make it worse by giving a lot of normal saline. Now, if normal saline's all you carry, talk to your medical director, or just
please
give
follow
them normal
your local
saline.
protocols.
Or just give them normal saline. I mean, you've got to do what you got to do.
Right.
And it's
they need volume.
far from perfect world. So,
100%.
So, again, we're still talking about acidosis, right?
Mm-hmm.
So what can we do in the field if we have someone in hypoperfusion and shock that's contributing to their lactic acidosis?
Ask the question again.
What can we do in the field
Mm-hmm.
to manage acidosis? So for hypoperfusion and shock, we can consider blood products if available.
Mm-hmm.
Mm-hmm. We can give meds or change their breathing.
Right. We can change their breathing. We can control hemorrhage.
Mm-hmm.
Permissive hypotension.
We can give
Balanced.
nice warm blankets.
Blankies.
Yes.
Yep. Minimize exposure to the environment if possible
Uh-huh.
with blankets or heaters or whatever it is. What about excessive IV fluids?
Excessive, is it ever acceptable?
No.
Yeah.
And every monitor now has a map on it, right? When you do the automatic blood pressure, it's going to calculate a map.
Mm-hmm.
So again, 65 is a great goal for that. Even if your blood pressure is like 80 over 60, that's probably a pretty good map still. Yeah.
Right.
So it's okay. Don't always get hung up on that number. And then if we could talk about shock index too, which is a great way to figure out where you are on the badness zone, but we can talk about that different time. So hypothermia, we're going to keep them warm. And I think we've got them all, right?
Mm-hmm.
And tidal CO2, where do we want it?
I mean,
735, 745.
or entitled 35, 45.
Yeah, 35 to 45. We're not hyperventilating people anymore.
Yeah.
We're not hypoventilating. Just keep it normal.
Mm-hmm.
All right. I feel like coagulopathy, which is the next one, is the most complicated. So
More complicated than what you just went through?
yeah.
Oh, Jesus.
No, this is good. We should, we've got all sorts of levels of providers that are listening to this. So let's touch on it.
Yeah, we'll deep dive and then we'll just bring it back up to the
Yeah.
surface to see how we're going to manage it in the pre-hospital
see
setting.
if we
Does that
lost
sound good?
Dan or, if,
Yeah. So we've touched on hypothermia now and acidosis. So we know hypothermia contributes to acidosis because your blood's not flowing, you're cold, and then acidosis can contribute to hypothermia by making it harder for your systems in your brain to function because you're not functioning within that 7.35 to 7.45. So let's talk about the third part of our triad, coagulopathy.
I'm trying to think of a nice memory aid. So lethal triad here: hypothermia, acidosis, coagulopathy. Hack. You need a hack
Yeah,
for the trauma triad. HAC.
I like it. So there's lots of reasons for coagulopathy, but we'll just focus on trauma-induced coagulopathy, which is very complicated. But again, remember our pop quiz at the beginning. why so many trauma patients die. It's from uncontrolled hemorrhage. And so knowing how the blood clots is really good for us because it just helps us to automatically start doing those things in our practice that, even if we forget the details, you're like, oh yeah, keep them warm, do this, do that, stop the bleed. So we're just going to talk about a few things, and this is where calcium really comes into the picture. So coagulopathy means you can't clot. So you have uncontrolled bleeding, increased transfusion requirements, worsened patient outcomes. And remember, blood loss is heat loss. So we're getting back into that triad again. So if you reach way back into your memory, we just briefly talked about acidosis and the Krebs cycle, the coagulation cascade. If everybody has forgotten about it, it's
We've
very
got a
complicated.
slide on it.
Yep, there's a slide on
for people to reference.
The important thing to know is that there's two pathways to getting to the common pathway of coagulation, which is the thing we know about, the thrombin, fibrinogen, creating the clot, right? So there's an intrinsic pathway, which has a lot more steps, but it's way more efficient. And every time one part of that pathway is activated, it like exponentially activates the next thing. So it goes pretty quick. Then there's the extrinsic pathway, which is mostly what we're thinking of when we see a trauma, is there's been a break in the skin, which releases something called tissue factor, and that starts the coagulation cascade from that direction. But they all end in the common pathway with the same result. Does that make sense?
Mm-hmm.
So you could have both things going on at the same time. You could just have one thing, But one of the things is that each of the so you have like factor 7, factor 12, you've heard of all of these things. In order to activate it, there's like a little protein on the end of it, and that has to be like cleaved to activate the next one. So there's all these things floating around that aren't activated yet. So the cascade activates one, which activates the next. In order to get down to the common pathway where we have the actual clotting happening, you have to have factor 10 converted to factor 10A, which is active, and you need calcium to do that. You need a few other things too, like phospholipids and other things, but mostly you need calcium in order to activate that part of the cascade. And calcium does so many other great things in our body, which helps our hearts beat. I mean, like when we have a hyperkalemia patient, we give calcium not for the hyperkalemia, but to protect the heart. So same exact thing here. Calcium is really just important to our bodies and all of the electrical systems in our body. So when we go back to talking about calcium, we're going to think about the coagulation cascade. And also, this cascade doesn't work well when our pH isn't between 7.35 and 7.45. And it also doesn't work well if you're cold. So a lot of things contribute to trauma-induced coagulopathy. Shock, because we're not perfusing, right? Acidosis, traumatic brain injury, which is really fascinating how that, I had to look that up because I was like, traumatic brain injury, how does that? So we can talk a little bit about that if you want to geek out on it. Hypothermia, hemodilution, so balanced resuscitation is really important here. Inflammation, which is going to happen no matter what kind of trauma you have. You're going to get lots of inflammatory processes happening. But remember, when we give lots of normal saline, that can also induce inflammation. So more balanced resuscitation, tissue injury, things like that. So there's lots of contributing factors.
Daniel, how are you doing?
I'm learning.
I like to act like I'm the one who's absorbing all this with no problems whatsoever. And I'm just checking in on you, my friend, to make sure you understand.
There's just a lot of shit I wish I would have known years ago.
Yeah.
I know. So thinking of the trauma triad, how are the other two things affect coagulation? So if you are hypothermic, the colder you are, the less like enzymatic activity you have in your body. And remember, in order to activate each part of the cascade, you have to have an enzyme that basically cleaves the protein on the end of it to activate the next thing, right? So
You have all these things floating around in your blood that aren't activated.
Yep.
What's
And
a
it
cleave?
Like,
That like
Cut.
like cut it. Yeah.
Okay.
Like activate it.
like
so,
a cleaver.
oh, got
So
it.
if you're cold, you don't have enough enzymes floating around to make
Okay.
the coagulation cascade work.
Yeah.
Or other things in your body, but particularly that. You have platelet dysfunction, so your platelets aren't working as well, which we'll kind of go into that too. There's a whole section of the coagulation cascade where you have fibrinolysis, so you're creating a clot, but you don't really want that clot to stay there. So you're also at the same time breaking it down, and that process can be affected when you're cold too. And that's important when it comes to having enough platelets to clot the things that you need and not bleeding too much to where you don't have enough platelets. Makes sense?
Mm-hmm.
And then that becomes DIC later on, that's a whole nother topic.
That's disseminated intravascular coagulation, Danielle.
Okay. So keep them warm so your body works right, okay?
I love that you don't have the slides.
You can have my slides.
I can't read. I didn't sit on your lap to do that.
Tissue injury and shock affects coagulopathy because remember when we have the extrinsic pathway we talked about, when you get a break in your skin, it releases tissue factor, which will then start the coagulation cascade, which we want. But if we have too much hemorrhage or you're not having enough blood circulating around, that's going to disrupt normal clot formation. Of course, we know that. And that's kind of like EMT 101 is you don't want the red stuff falling out onto the floor to start being clear stuff. So that goes right into, again, hemodilution and balanced resuscitation. Hemodilution is bad because if we don't have blood products like plasma and platelets, then we can't clot. So again, you don't want to be replacing your blood with normal saline or lactated ringers if you can help it. It'd be really cool if everybody had the ability to give at least packed red blood cells, but we don't. All right, I'm trying to figure out how to not go too deep into the woods here. But TBI is really interesting because brain tissue has a lot of tissue factor, which I didn't know this, but it's like really rich in tissue factor. So if you do get a brain injury, and remember tissue factor can start the coagulation cascade. If you get a brain injury and a lot of tissue factor is released, then it starts to trigger DIC. So basically what you're going to be doing is it's going to be saying, I need a ton of platelets because I'm bleeding. But then if you use up all your platelets, there's not enough platelets to stop the other bleeding, which means you bleed more. And so that can really cause...
You're saying bleeding in the brain.
Mm-hmm. Or in the body.
Right, but
Yep.
it's going to release more because the brain is saying it to stop that, but it's not going to go down into the body to stop.
Yep. So there's another part of this slide talking about consumption coagulopathy, which is basically DIC. So trauma triggers clotting, leading to depletion of your clotting factors, and then now you get excessive clotting and excessive bleeding, and it's just a big mess. So pregnant women are at high risk for DIC. Trauma patients that have had like massive transfusion, also big risk. So let's talk about how crystalloids, which we have already talked about quite a bit, can contribute to coagulopathy. Excessive crystalloid resuscitation and the absence of plasma increases coagulopathy. So this is why we want to do permissive hypotension. If you have a 500 mil fluid bolus, which is really not very much, like we're talking normally in a trauma patient, you're getting 1 liter or 2 liters, right? Just 500 mils of fluid can increase your coagulopathy by 10%.
Wow.
So if you give a whole 2 liters of fluid, you can increase coagulopathy by 40%.
Jeez.
And sometimes we can't get around this because they have no blood pressure. We have to do something. So we're giving them lots of fluids. But just know in your mind, the more fluids I give, the less they're going to be able to clot, the more I'm diluting their blood, and the more they're, going to continue bleeding. And we've all probably been in this situation. We're like, no matter what we do, it's just getting worse and worse. We're probably contributing to it with the crystalloid resuscitation. But again, if that's all you have, that's all you have. So nobody has to be perfect here.
So it's obviously better than not giving it.
Mhm. Yeah.
For sure.
And if you have agencies around you, let's say you've got a long transport that gives blood, it might be worth it to give them a call and start getting that blood on board. Packed red blood cells aren't as great as whole blood, but it's better than just dumping more fluids into the person. At least red blood cells carry oxygen and things like that. So normally when you're in an ER, ICU, you're doing, like blood, platelets, plasma, you're doing all of it together, not just packed red blood cells. And then I'm not exactly sure. I don't have a lot of experience with whole blood. That's just not something that I've had tons of experience with. But that's got all the components of blood in it. So if you have access to whole blood, that seems like a really good option too. I know some places in the South are carrying whole blood on their EMS units. So, okay, so the burning question is, what about calcium?
Yeah. How does that help? Why is it the fourth thing?
How
Why is it so good? Why does everyone love it?
everybody
And why are we not giving
loves
it?
calcium.
Yeah. And
Well-
is this just a fad or is this legit?
Nope, it's legit.
'Kay.
It's legit. We talked about in the coagulation cascade how you need calcium to actually activate factor 10.
Mm-hmm.
One of the things that can activate it to make the common pathway happen where you're actually clotting. So that's important to have. Hypocalcemia obviously impairs clot formation for that same reason. And if you already have someone that's bleeding, you're putting them at higher risk for uncontrolled bleeding, which is one of the biggest reasons people die after getting to the hospital. Massive transfusion. Any agency that does trauma transfers, so you're going to pick up a trauma patient from one hospital, take them to the next, and they've been massively transfused, that's a good time to ask, did you check their calcium?
Mm-hmm.
And nowadays, it's pretty standard, but even just 5 years ago, I feel like it wasn't really standard to think about that, especially as EMS providers. So we want to make sure what's their calcium level. When you give a massive transfusion, the citrate in the blood product binds to the calcium, and so it can cause hypocalcemia just by getting a massive blood transfusion. So you want to just be able to balance those two things with just giving them an amp of calcium.
Cool.
Or whatever your protocols say.
Yeah. Always follow your local protocols,
Always.
Daniel.
Some EMS agencies now are like for every 2 units, we give an amp of calcium or something like that. So it's becoming part of their protocol. But if you don't carry blood products, you're not innocent in this, especially if you're transporting people who have had a massive transfusion. Just make sure that they know, check their calcium.
Mm-hmm.
Calcium affects acidosis too, which is the other part of our triad. It reduces calcium binding to albumin, which can actually lead to an increase in calcium initially. But as you get more acidosis, the calcium becomes more impaired. So you might have someone at first who seems just fine, but then later gets hypocalcemic. So if you're doing trauma transfers again, or if you're taking care of trauma patients maybe a couple days later, just remember that even if it was initially normal, it could get worse.
Okay.
And then, of course, hypocalcemia is good for cardiovascular function, right? So if you're hypocalcemic and your heart's not pumping effectively, then you can get hypoperfusion, shock, and more acidosis. So we got to have our calcium. And then hypothermia. Remember, our bodies like to work within a nice little warm temperature. So if you have hypothermia, it can impair the calcium metabolism, and that leads to decreased myocardial contractility, worsening shock and hypotension, just like we talked about. And then we talked about how cold temperatures can slow down the enzymatic activity that we need for the coagulation cascade, and that can be detrimental because it can cause more bleeding. So each of these things actually really are affected by calcium, and it is really important for the entire cascade to add calcium in. So I guess we'll call it the trauma diamond.
Diamond's cooler
Which
than a
doesn't-
square.
It is.
Yeah.
But not as cool
It
as
just
a triad.
sounds more
Not as cool as a
hopeful.
triad. Yeah.
Sounds more hopeful.
Yeah.
Trauma diamond. Do you guys use the shock index at all?
We don't. No.
I mean, it's a really easy way to see like how bad off is my patient. So the shock index is heart rate divided by systolic blood pressure. So if your heart rate's 110 and your systolic blood pressure is 110, that equals 1, right?
Mhm.
The closer you get to 1 is bad.
Mhm.
So we really want to be lower than that. So we want a little bit more gap in there. So if you're tachycardic with a low blood pressure, your shock index is going to be close to 1 or more, and you know that your patient's probably going to start circling the drain. So it's a pretty easy way just to gauge what's going on with your patient. Especially if you're not sure, like you have grandma whose blood pressure is 80/60. Is that normal for her?
Right.
Or is she in shock? You know,
Mhm.
if you use the shock index and her blood, you know, or her heart rate's 60 or 70, then, you know, you're probably okay.
Mhm.
It is important to remember too, like for the shock index, are they tachycardic because they're scared out of their minds
Mhm.
and they have a normal blood pressure? Or are they tachycardic because they're compensating for blood loss somewhere? So, you know, clinical picture is the most important. These tools are just kind of good ways to check yourself. Okay, so we talked about a ton of stuff, but I think the most important part of this podcast is how do you manage this in the EMS world?
Yeah.
There's lots
Let's
of
wrap
reasons,
it up with
lots of ways you can manage it in the
what we do.
hospital. But what do we do? So the very first thing we want to do is
Stop the bleed.
stop the
Yes.
bleed.
Yeah, Daniel.
Yes.
Did it.
Yeah.
The easiest thing: tourniquets, pelvic binders. Talking about stop the bleed, permissive hypotension is the next thing. We really want to have our MAP 65. For TBI, we want it around 70 or more, but we don't need to have our blood pressures looking perfect.
80 to 90.
Yeah.
Even 70, depending on what's going on.
Right.
Yeah.
Yeah. And I really like the MAP. If you forget systolic blood pressure times 2 plus the diastolic pressure divided by 3, that's basically MAP. That's too much work. So that's why your monitor does that for you.
Thank goodness.
Yeah.
Jeez.
Yeah, man.
Did they have a radial pulse?
Yeah.
Yeah. And then the other thing for EMS management, early blood product administration, if available, whole blood, packed red blood cells, whatever you have or whatever your agency has. If you don't have blood products, remember just the balanced resuscitation. Try to resuscitate with lactated ringers if you have it. And that way you can just avoid hyperchloremic acidosis and you're good to go.
Awesome.
Prevent hypothermia.
Mm-hmm.
That's another thing we can do. I mean, that's pretty easy
Mm-hmm.
in some cases. I mean, not always. So that's the best thing about EMS is everything looks great on paper until you actually run the call and
Right.
everything goes out the
Mhm.
window. So
Mm-hmm.
we get it. Resuscitate before you intubate. That's a really important thing that you should always remember no matter what the situation is. If it's sepsis, if it's trauma, if it's anything, always resuscitate before you intubate. And then calcium administration. If you have it and they've had a blood transfusion and it's in your protocols, that might be something to consider.
What is generally the dose on that?
It's just 1
It's
gram
still
usually.
the 1 gram.
Yeah.
For
think-
chloride?
Yeah, calcium chloride. Isn't that what most people, or do people do
I feel like
calcium
we
gluconate?
switched a while back to calcium gluconate
I think
far
we
more
have gluconate.
commonly than
Okay.
chloride. Just due to
2
the
to 3 grams then, calcium
So,
gluconate?
yeah.
So, yeah. So it
It's-
just depends. So I think calcium's really important. If you remember, the blood products you give is going to bind to the calcium and deplete it that way. Then you want to replace it.
Mhm.
In a regular trauma patient that you're not giving blood products to, it's probably not that important. If you have a regular trauma patient who's bleeding out and, you know, they have all the things, they should still have calcium in their body unless they've bled all of their blood out onto the floor, which they might have. So, and again, unless you're giving massive transfusion or giving blood products, the calcium component probably isn't as important. And I think that's why it's confusing to put it into the trauma triad, because it really only matters if you're giving blood or if they've gotten blood. And that's generally. Of course, it matters for other very minuscule things in your body, but that's the biggest way you're going to deplete your calcium is with blood products being administered.
Okay.
I think that's why it's just taken a slow trip to get into the trauma triad for EMS providers, because most of us don't give blood in the field. And if you do, it's probably going to be in your protocol. And then TXA. We didn't talk much about TXA, but I mean, give it. It reduces
you got it.
mortality.
Yeah.
You're also stopping the bleed with TXA. I think everybody carries that now, pretty much. Yeah.
So
We do have a scenario if you guys want to run through it.
yeah, let's do a scenario.
But we'll set up the scenario. You have a 40-year-old male on his way home from work, head on into a tree. It's afternoon in the Northwest, and it's 50 degrees outside. It's thankfully not raining. What do you think? What do you want to know?
As we arrive, what do we see?
So you have a small pickup, like a F-150, into a tree.
Okay.
There's massive intrusion into the front compartment. Patient's trapped.
Okay.
One patient. As you walk up, you see a 40-ish-year-old male. He is having repetitive questioning.
Okay.
And he's complaining of his legs hurting.
Okay.
So I always think like sick or not sick.
Oh yeah,
Sick.
he's sick.
Yeah. Mm-hmm.
What do we got on scene for extrication? How long is that going to take?
Can
we get someone into the patient compartment to start patient care?
Yep. So you can get someone. You can't get into the patient compartment because it's basically like crushed all the way up to the back of the cab. But it's a very rural community.
Okay.
So you have one volunteer fire department on scene. You have another one coming with extrication equipment. And so right now we're just
Trying to manage where we're
primary
at.
assessment. Yeah.
Okay. Are there any tools to start extrication?
No, not yet.
Bummer.
Yeah.
We have air ambulance on the way.
And
Okay.
it doesn't matter how far away they are because your patient's stuck.
Yeah.
Yep.
Yeah. But you do have air ambulance on the way.
Okay.
And they usually will carry blood. So that's
Right.
a good thing to know.
What are we seeing as we access patient compartment? If I'm doing a head to toe on this guy, what am I noticing?
Okay, so
about
head to
him.
toe, you have bruising across the chest from the seatbelt.
Okay.
Lung sounds are clear.
Good.
Abdomen is rigid.
Not good.
Tenderness on the right lower quadrant and right upper quadrant. Still being extricated, so you can't really assess
Right.
the pelvis. He's complaining of pain in his left leg. He has an obvious deformity of his thigh. But again, you can't really get in there to assess pulses or anything.
But we can't see any active bleeding. We need to stop
No,
right now.
Nope. I mean, he does have blood around in his jeans from his thigh. Blood all over his face.
We got to cut those pants down.
Got to cut those pants off.
Yep.
He can move both feet, but you can't really get down there to assess him. But he says he can move them.
Mm-hmm.
And that's kind of where we're at right now. So.
Okay.
And then whenever we do March, in my mind, I always add marched with a D on the end because March kind of leaves out the disability. Like, is he alert and oriented?
Mm-hmm.
What's his GCS? So in this situation, he's alert to verbal. GCS is 14, and his pupils are equal and reactive.
Can we get some vitals on him?
Yep. So vitals are heart rate 110.
Okay.
BP 96/60.
Okay. So he's
So shock index is already
Yep.
alarming.
He's compensating.
But if we were in just kind of hanging out here, and my blood pressure is
Right.
96/60, that could be tricky.
Mm-hmm.
SATs of 90%, respirations 22 and shallow.
So he needs high flow too.
Mhm.
Needs to make sure we got the bleeding stop that we can see.
Mm-hmm.
Yeah. Can we cut the pants?
Yep.
Can we take a look?
Yeah, and like just with this scenario, what's your differential diagnosis right now? Like, what are you thinking of all the different things that could be wrong?
Oh, you got belly bleed.
Multi-trauma.
You
Yep.
got something in the chest going on.
Right.
Pelvic.
Watch those lungs. The pelvic guy's going to need a pelvic
Right.
sling.
Femur.
Femur.
Mm-hmm.
He's confused.
Yeah. He's really smacked his head good.
He's trapped. So he's got the whole cab sitting on his
Mhm.
legs. So if we think about this in the trauma triad,
Well, we almost want to treat this kind of like because we're going to be lifting basically the engine compartment off this guy.
Yeah.
Are we going to want to treat him similarly like we have a crush patient?
sure. I mean, what if this is an hour-long extrication?
Which it very well
It
could
very
be.
well could
Yeah.
be, given where we're at. Yeah.
Yeah.
Okay.
And just for background, I was on scene for over an hour as the flight crew, as like this third or fourth person on scene. So it was well over an hour and a half of time from impact to time of transport. So
Bummer.
so we've got hypothermia to consider.
Mm-hmm.
we didn't really have anything to keep him warm. That was kind of a
No
bummer.
heater blower, no ready heats.
Mm-mm.
Mm.
No.
Okay.
I mean, we put a ready heat on him when we got there, but it had already been a half hour.
Okay.
Mm-hmm.
How far away are you from a trauma hospital?
8 minutes by air.
Flight. Yeah.
Mhm.
Okay.
45 minutes by ground.
Okay.
So
we
hypothermia.
flying.
Keep him warm.
Mm-hmm.
Some things that are contributing to his hypothermia could be blood loss,
Totally. It's absolutely blood loss.
maybe a TBI.
Mm-hmm.
What about acidosis?
Yeah,
Some
I'm
things.
concerned about the respiratory rate.
Mm-hmm.
Respiratory rate. So
And
we got
shallow.
respiratory acidosis.
Mm-hmm.
He's cold, so that's going to
Mhm.
contribute. He's probably bleeding out. He's got a possible crush injury, which could
Yeah.
contribute to acidosis.
So you want to have your bilateral IVs in
Mhm.
prior to the extrication.
Yep.
Think
And
about the
then-
crush injury protocol.
Yep.
Mm-hmm.
And then for coagulopathy, some contributing factors would be the cold, the acidosis.
I mean, this is kind of
And this is just a run-of-the-mill trauma
sucks.
patient.
Well, right, but the thing that sucks about it is we don't stay on scene for an hour and a half with people unless we, are
Unless you
forced
have
to,
to,
right?
Yeah.
And so, like at one point, I'm going, okay, well, am I going to need to call in
I know, exactly.
for treating this person beyond what I typically do for the 20 minutes I
Yeah.
usually have someone?
Yeah.
Yeah.
And like you're speaking to all the EMS providers on the ground that aren't firefighters, or maybe the ones who transport that
Mhm.
do have patients for an hour or longer considering during transport. How am I going to change what I'm going to do now that we're 2 hours into this,
Mm-hmm. Yeah.
So this is a run-of-the-mill trauma patient, I would say. And already we've identified like 10 things that could be contributing to his mortality rate increase and also the trauma triad. So you've been doing all these things in the background, maybe just not as intentionally.
Totally.
So keep him warm. You said start 2 IVs. Give him some fluids,
Mm-hmm.
probably LR, right?
Yep.
Yep.
Yeah.
Love the LR.
Love the LR.
Love the LR now. And then when the flight crew gets there, they could start blood
Mm-hmm.
Mm-hmm.
if you feel like they need it. If they're
Yeah.
starting to deteriorate or their shock index is getting higher,
Mhm.
things like that. I would imagine with a rigid belly and some deformed left femur that you've got massive bleeding.
Mm-hmm.
Okay, so let's say they extricate him. What are you worried about during extrication?
Pain management.
Pain management?
Releasing all those toxins.
Yeah.
Yep.
Mm-hmm.
Pulling that off him and then releasing a bunch of stuff that's been stored up.
Yeah. And then
Um,
also that's probably been protecting his blood pressure.
Yep.
Mm-hmm.
So now
Yep.
we might lose a pressure. Without pressure, you might lose mentation. So
Mhm.
yeah, lots of things to consider.
That's why being proactive on the blood, even though maybe you typically wouldn't give blood to this dude, like think
Yeah.
what could happen.
Yep.
Maybe we should give it now before it happens.
Yeah.
Resuscitate before you extricate. Look at that.
Hey,
There, I love
there's
that.
the new course from Daniel.
Resuscitate before you extricate. I
Yeah.
love that.
Yeah.
Yeah.
Which we ended up doing in this scenario because we knew he was going to get intubated. His mentation was deteriorating, but we didn't want to intubate before we resuscitate.
Right.
So
Started early.
Mhm.
resuscitate before you extricate.
So I'm thinking, obviously, little pickup, just cut the roof off, push the dash, and pull him out
Mhm.
the back.
Yeah.
And then that's going to be painful as hell, assuming he's still, obviously, whether he's screaming or not, it's going to be
Mhm.
painful. We just got to treat that as we can, given the limitations of blood pressure and everything else.
Yeah.
So
Ketamine?
Sure.
What are you thinking?
ketamine's great.
Yeah. Yeah.
But so you got 8-minute flight time.
Mhm.
We all want to intubate,
Yeah,
right?
we do.
Do you think we should take the 10 to 15 minutes in the back of the ambulance to intubate as opposed to have suction ready, good BVM techniques?
Hmm.
You pull him out into the bed of that pickup and do it there
No,
We
Well,
actually
maybe
had
not.
lots of time.
to RSI him and then
Yeah,
put him in
maybe-
the back of the ambulance?
maybe not RSI. We have
You thinking,
maybe
Like
flight
PSI?
time?
yeah,
No,
thinking
maybe
more-
maybe not.
Oh, I'm hearing what you're saying.
Managing the airway via BVM and suction
Yes. Hmm.
and get him to the trauma center where they need to open him up and stop that bleed.
right.
You're right. Yeah, airway management does not always mean intubate. So I love that.
And we're past our golden hour mark with this
Yeah.
guy.
Yeah.
So
We
Shoot,
did
man.
intubate him on scene,
Mhm.
but we had, the flight crew. We have to look busy, right?
Yeah, we
Totally.
gotta do
So
something.
we were like
got those
setting
helmets
up,
on.
It is fun,
Yeah.
setting up
right?
all
Yeah.
our stuff because we can't get near the extrication. We don't have any protective gear on,
No.
which really sucks because you want to
Mhm.
get in there and do stuff. But
Yep.
so we're setting up everything. We had it all set up perfect. So extricated, intubated, go. We already agreed you get one pass intubation and then it's an iGel because we knew he was going to need surgery pretty quick. And he did end up having a large liver laceration, which I think your liver gets like 25% of your cardiac output or something like that, or is it 40%?
Something massive.
Yeah. So, I mean, you're just like pumping blood directly out of your body.
Right.
Or into your body, I guess. So he ended up having a good outcome. But there was a lot of communication on scene about how are we going to mitigate each thing. Because we did have time. Sometimes you don't have time, but it worked out okay on this one.
What would you have changed?
Keeping him warm longer. Trauma's a naked sport, we always say. And how often do you put a flimsy blanket on him and you're not really keeping him warm? So if I could think of anything in my entire career that I could change, I would have kept people warmer.
Keep people warm.
Yeah, which is so easy to do.
It's so easy.
But you think of, I don't know, intubating and doing all these other hard skills where you really just could keep people warm. And all right. Any
that was an awesome
final
one.
thoughts?
I like how we wrapped that up with a nice little scenario. Put all the pieces together. Lot to dissect on that one, though, because there's so many components of this that are, I don't want to say above our heads, but
it's above my head.
It's
say that.
Yeah. I mean, it's kind of things we need to.
It's not something that you're daily thinking about.
Yeah. It's definitely continuing the education that we received on these topics.
This is one of our podcasts I'll listen to
15 times.
Yeah, just
well, we didn't go into a lot of the
There's more.
deep dive.
Yeah. We'll post the slides for everybody.
Yeah.
There's a lot here, but this is great. Lots to chew on and marinate on. Awesome. Well, let's leave it there for our listeners, and we'll catch everybody on the next episode. Appreciate all you guys, and we'll catch you on the next one.